Okay. Welcome to November Journal Club. We have two exceptional PGY4 residents presenting today. Before we begin, we would like to make ongoing efforts towards reconciliation with Indigenous communities. And by way of a land acknowledgement, I would like to offer a reading of Article 24 of the United Nations Declaration on the Rights of Indigenous Peoples, which is included as a document on the path towards reconciliation. Article 24 reads, Indigenous peoples have the right to their traditional medicine and to maintain their health practices, including the conservation of their vital medicinal plants, animals, and minerals. Indigenous individuals also have the right to access, without any discrimination, all social and health services. As our program learned during an exceptional academic half day led by Amanda and Guillaume and Dr. Norris, wearing the Indigenous medicine wheel pin can help Indigenous people feel more comfortable reaching out to access health practices while under your care. We have two great presentations today. Our first speaker, Dr. Peter Hoang, PGY4 Geriatric Medicine resident, and with an academic interest in marginalized older adult populations, is here to present on supine versus seated assessment of orthostatic hypotension. That, Peter, please feel free to start. I think your microphone is still muted.
Thanks for the introduction, Dr. Gandel. I'll be presenting today on comparison of supine and seated orthostatic hypotension assessments and their association with falls and orthostatic symptoms. This study was published in the Journal of American Geriatric Society in August 2022. I have no conflicts of interest to declare. For our outline and objectives, we'll go over the background on the physiology of orthostatic hypotension, review the study rationale and methods. We'll have a quick primer on generalized linear models to generalized estimating equations, go over the pertinent study results, and a critical appraisal. I first start by asking the audience to consider a busy outpatient clinic setting, perhaps with a broken bed that's too high for an older adult to easily get onto. When measuring postural blood pressures, I have found it easier to go from sitting to standing. But am I missing a proportion of patients by doing that? I chose this article to answer this question. Maintenance of normal tension depends on normal plasma volume, intact baroreflexes, and normal venomotor tone. The splanchnic circulation accounts for a large amount of total blood volume, and this can increase by 200 to 300% after a meal. Similarly, when standing, 300 to 800 cc's, or in other words, in the average person, up to about 15%, of blood pools into the lower extremities and splanchnic circulation. This pathway takes input from baroreceptors along places such as the aortic arch to send signals to the rest of the midbrain to increase heart rate, and parts of the medulla to cause sympathetic activity for skeletal muscle and splanchnic vessel circulation, which in turn increases peripheral vascular resistance. A loss of any of these components can result in orthostatic hypotension, to which the consequences are well familiar to this audience. The JAMA Rational Clinical Examination uses a supine time of 2 minutes before standing to measure blood pressure. Upon standing, blood pressure is measured sometime between 1 and 3 minutes after standing, based on the American Academy of Neurology guidelines and the JAMA. The definition of orthostatic hypotension remains a systolic drop of 20 and a diastolic drop of 10. The Atherosclerosis Risk in Community Studies, or ARIC, study later showed that orthostatic hypotension within 1 minute was more associated with symptoms of falls, dizziness, falls, syncope, and fractures, more so than those after 1 minute. Despite these landmark studies and guidelines recommending a supine to standing measurement, for a multitude of reasons, sit to standing is still performed in clinical settings. As such, the study objective was to ask these two questions. Number 1, is orthostatic hypotension more frequently detected supine to standing or sitting to standing? And number 2, which is more associated with falls and symptoms of orthostatic hypotension, supine to standing or sitting to standing? Participants came from the study to understand fall reduction and vitamin D in U, or the STURDY trial. Inclusion criteria, as seen on the left, included adults who were age 70 or older, who were non-institutionalized, at a high risk of falling, defined as a history of at least one fall in the past year, fear of falls, use of a gait aid, or difficulty maintaining balance with ADLs. They had a low vitamin D level and were not on vitamin D or calcium supplementation. Participants were excluded on the basis of cognitive impairment defined as an MMSE under 24, an abnormal calcium level, or a history of kidney stones. I would first like to start by orienting the audience to the baseline visit. Participants start at the baseline visit that only use the sitting protocol. 2 weeks later, they return for quote unquote the randomization visit where they had the supine protocol. Following that, for every subsequent visit at 3, 12, and 24 months, the sitting protocol was done first, followed by the supine protocol sometime afterwards on the same day. For all types of measurements, the arm was set to a position of 70 to 80 degrees to the angle of the heart. For the sitting protocol, participants sat for 5 minutes with their backs supported, legs uncrossed, and feet flat on the ground. 3 measurements were taken, separated by 30 seconds. Afterwards, they were asked to stand, and after 1 minute from the time both feet were on the ground, they had 3 additional measurements separated by 30 seconds. For the supine protocol, participants lied for 5 minutes prior to measurement, and then had 3 measurements separated by 5 seconds. Upon standing, they were once again measured with 3 measures, this time separated by 5 seconds, and immediately once both feet were on the ground. This was then repeated 3 minutes after standing. Staff were asked to perform assessments prior to phlebotomy and physical function assessments, and participants were required to wait at least 30 minutes after smoking, exercise, meals, or caffeine. There were 3 important outcomes that were measured: orthostatic hypotension, falls, and its symptoms. The standard definition of orthostatic hypotension was used, a drop of at least 20 in systolic or 10 diastolic millimeters of mercury. Falls were self-reported by participants wherein they documented their falls for a calendar for up to 2 years. There were many symptoms that were included in orthostatic symptoms, and participants were asked if they had any of the following in the preceding 30 days. And these were measured on a Likert scale from 1 to 9 at each visit. This included dizziness, lightheadedness, fainting, syncope, seeing spots, imbalance, room spinning, among others. Pre-syncopal symptoms were also measured after standing during the blood pressure assessment. Analysis was restricted to participants who had both seated and supine protocol pairs, which were averaged among all available measurements. This included participants who had the baseline and then the randomization visit 2 weeks later. For the basic data, they had patient demographics as well as scatter plot of the data to visualize changes in blood pressure. Generalized estimating equations were used to determine the prevalence of orthostatic hypotension, the mean blood pressures, and the relationship between symptoms by protocol. Cumulative incidence plots were used to determine the absolute risk of falls, and Cox proportional hazards were used to model the relative risk of falls. Before we jump into the data, I found that this was a great learning opportunity for me to learn about the type of analysis that was done in this study. I asked that the audience goes down to a trip through memory lane or their biggest nightmares to high school and college math. A linear model is one that is defined where y can be found based on any value of x with a coefficient and any number of variables of interest. However, it uses a normal distribution such that every value you obtain here is based on the probability of obtaining that value under a normal distribution. A generalized linear model improves upon that by allowing to use any type of distribution, for example, a Poisson. Both of these make the assumption that each and every individual measurement is independent of the other, a situation that would not be seen, for example, with repeated measures or a different cluster of patients. This is where mixed linear models come in. Each color corresponds to a cluster, and this model adds further covariates that in summary accounts for differences between and within subjects. You can again add any number of effects that you think would create variation. In this specific example, it would be blood pressure between different subjects and then along repeated measures for the same person. Whereas a mixed linear model, just like a linear model uses a normal distribution, a generalized linear mixed model uses any type. It's great that I can determine the effect with individuals and between. but what if I just want to know the overall effect? What if I just want to know the overall prevalence of orthostatic hypotension accounting for repeated measures? This is where generalized estimating equations come in. It models a population average among clusters and is easier to do than having to account for the complex designs in generalized mixed models. With that in mind, I return to the results of this study. Out of 688 participants that were recruited, 534 consisted of the sample that had paired sitting and supine measurements. 933 assessments were made in total across the quote-unquote 4 time points. The average participant was 76, male, with a baseline blood pressure of 130 on 68, had a history of hypertension, were using an antihypertensive, most likely to be an ACE inhibitor, did not have diabetes, falling, and had a BMI of 30. I've highlighted for the audience some of the notable differences in the sample highlighted in red. For the seated group with orthostatic hypotension, participants were more likely to be female, African American, have a history of Parkinson's disease, a history of hypertension, again an ACE or ARB use, and have a fall in the past year. 3.9% of participants had seated orthostatic hypotension compared to 20% who had supine orthostatic hypotension at any point in the study. While there were no recurrences of orthostatic hypotension in the seated protocol, some participants with supine orthostatic hypotension had this repeated when measured again. This measure is consistent with meta-analysis data showing that about 20% of community-dwelling older adults have orthostatic hypotension. Among the 933 assessments, orthostatic hypotension was identified in 2.1% for the seated, 15% for the supine, and 0.9% for both seated and supine. And while there was a mean increase of about 4/3 millimeters of mercury for the sitting protocol, there was a mean drop of -4 and -1 for the supine. 204 participants experienced at least one of the 481 falls observed over a median of 1.7 years. The range of falls was large, between 1 and 35, with 20 falls in the seated group having orthostatic hypotension and 189 falls in the supine group. Neither seated or supine were significantly associated with falls, as shown with these hazard ratios that cross 0. However, supine systolic orthostatic hypotension had a significant hazard ratio of 1.77, and this was the most notable outcome associated with falls and did not change with sensitivity analysis. There was a plethora of symptoms that were asked, and while seated was not significantly associated with any symptoms, for supine orthostatic hypotension, there were associations with fainting, blacking out, the room spinning, and seeing spots, as shown in the slide below. For critical appraisal, I used the Joanna-Briggs checklist for cohort studies using relevant questions. This is not meant to be exhaustive and hopefully to build discussion. Number 1, were confounding factors identified? A number of confounding factors were identified. For example, for Cox proportional hazards for the risk of falls, these were adjusted for age, race, and center. However, one wonders if other things that could have been confounders might include the type and number of antihypertensives, particularly diuretics or calcium channel blockers, as well as the control of hypertension. As such, I gave this outcome an unclear. Number 2, were outcomes measured in a valid and reliable way? Outcomes were measured with a clear protocol for staff, and self-reported measures were collected probably as accurately as possible within this relatively large sample size. It's unclear why a shorter pause was used for supine versus seated measures. That was 5 and 30 seconds respectively. There are some theories that suggest that the first blood pressure measurement causes venous congestion that may affect subsequent ones, but studies seem to have gone back and forth as to whether this makes a difference. Participants also had the supine protocol done at any later point of the day, and we don't know how long after. There are diurnal variations in blood pressure, and perhaps this may overcall the presence of supine orthostatic hypotension. Albeit, I still think this is an important measure, so I gave it a yes. Was the follow-up time reported and sufficiently long enough for outcomes to occur? I found that the follow-up time was clearly reported, and for falls and symptoms, a 2-year study is more than sufficient. So I gave it a yes. Number 4, was follow-up complete? And if not, were the reasons to loss to follow-up described and explored? In their sample of 534 participants, there were only 189 pairs of assessments in the last follow-up. The authors do report that included and excluded arms were similar, though no formal analysis done. We're unsure of the reasons for the lack of paired measures and follow-up as well. It's unclear the number of measurements per participants. Were there many participants who had repeated orthostatic hypotension, or only a few who had multiple recurrent episodes? As such, I gave this outcome an unclear. Number 5, were strategies used to address incomplete follow-up utilized? Related to number 4, there's no reporting of these strategies. In addition, generalized estimating equations does not account for missing data, and this can potentially create bias. For example, did participants not have a paired measure due to a fall, injury, or not liking the possibility of experiencing symptoms of orthostatic hypotension? As such, I gave this outcome a no. Number 6, was appropriate statistical analysis used? The 2 overall statistical tools used, generalized estimating equations and Cox/cumulative measures, were appropriate tools for determining prevalence and high-level factors accounting for repeated measures, recognizing its limitation. As such, I gave this item a yes. Overall, supine orthostatic hypotension is more readily detected and more associated with symptoms. The presence of orthostatic hypotension, either seated or standing, is not associated with falls. The only component that would be is supine systolic orthostatic hypotension. From a practice perspective, one wonders if a different threshold number should be used for seated orthostatic hypotension in older adults. Finally, we should ensure that clinic rooms have accessible, functioning, elevating tables and beds to rest the arm upon standing. For my bottom line, in community-dwelling older adults at risk of falls, a supine to standing protocol is more effective in detecting clinically relevant orthostatic hypotension. Thank you.
Great. Thank you very much, Peter. Excellently presented, and very much appreciate the analysis of the methods. Shabir in the chat mentions beautifully presented, lovely set of illustrative slides. For hazard ratios, unity is 1, not 0. And OMG, it's not an RCT we're discussing. So thank you for that expression. Importantly, GCAN account for missing data, but do not automatically. I don't know if you want to respond to that, Peter.
I require further study with regards to biostatistics, but my understanding is that you have to be certain with the type of assumptions that you're making when measuring the way data might be missing.
Okay, Barb has her hand up. Go ahead, please.
Thanks. Just quickly, I wonder if there's a role for looking at the blood pressure between supine and sitting. I think that the key thing is getting the change of the legs from a horizontal to a dangling position, and that the supine to sitting may be informative, because that's also sort of more of a real world progression of change in position. Like most people don't leap out of bed, they sit on the edge of the bed first. And that also ties to the mistake we make in hospital. Sometimes I see residents do the blood pressure with the head of the bed down, and then they raise the head of the bed. But what you actually have to do is get the legs over the edge of the bed and dangle them.
Thank you. Further comments, Gary mentions beautifully presented in the chat box, and Shabir has a follow-up question. Did the authors describe interventions for people with observed OH?
They did not. And one imagines over the course of 2 years, for someone who is a population 70% that's having falls, some sort of intervention must be done that can potentially be a confounding factor. More, I guess, relevant for the Cox analysis data than the overall prevalence, I felt.
Thank you. And I see Gary turned his camera on. Not sure if you have a question as well or a comment.
Thank you. Beautifully presented, Peter. I don't know if I see Barry here, so I'll speak for the gray hairs who always were trying to encourage the residents to test for orthostatic hypotension from the supine to standing position, with people often cutting corners, not only as Barb showed, but sometimes doing the standing first and then doing a lying blood pressure later. So having someone that actually studied this really, I think is great. I mean, I always thought about it in a very simple way, that it has to do with gravity. And it seemed to me to make a lot of sense that you'd want to go from lying to standing to maximize the gravitational pull, which could put the person at highest risk of orthostatic hypotension. Peter, is that an overly simplistic way of looking at this?
I don't think it's overly simplistic and it's practical. I think for the purposes of, like, again, you're trying to capture a group population, trying to find orthostatic hypotension in them, and using the method that would help you find it as best as possible with gravity, I think makes a lot of sense.
So just like a greater stress test, because there's a greater gravitational pull when you're standing up versus sitting. Anyways, great presentation. Thank you.
Thank you very much. I agree practically and pragmatically, if there were chairs or bed that made this easier in terms of functionally positioning the patient, that would be helpful. So thank you very much, Peter. For the sake of time, we will move on. Our second speaker this morning is Dr. Victoria Chuen. Also, welcome to Journal Club, PGY4 Geriatric Medicine resident, also leading a study on language concordant assessment in her spare time, and is here to present on longitudinal and cognitive changes in Alzheimer's disease in Down syndrome. Victoria, please feel free to share your slides and to start.
Great, thanks so much, Dr. Gandel. Can you see my slides appropriately? Yes, okay, thanks so much. So today I'm going to be presenting on a paper titled Longitudinal Clinical and Cognitive Changes Along the Alzheimer's Disease Continuum in Down Syndrome. I have no conflicts of interest to disclose. Our objectives for today are first to review the prevalence and pathophysiology of Alzheimer's disease development in individuals with Down syndrome. We'll then discuss some of the available tools used to help diagnose dementia and monitor for cognitive decline in individuals with Down syndrome. We'll then critically review the methods and the results of our selected paper, perform our critical appraisal, and then finally summarize our bottom line. So to begin, Down syndrome is the most common genetic cause of intellectual disability worldwide, and it continues to have stable prevalence over the last 2 decades, affecting 1 in 750 live births in Canada every year. Most often, the cause for Down syndrome, commonly known as trisomy 21, is due to the presence of an additional copy of chromosome 21, leading to a total of 3 copies, as you can see here. In a small minority of individuals, about 3% of cases, it's due to a Robertsonian translocation, where essentially this chromosome 21 material has broken off and attached itself to another chromosome. That's commonly chromosome 14. But regardless of where this extra chromosome 21 material is found, its presence results in an increased risk of multiple comorbidities, ranging from cardiac defects, endocrine issues such as hypothyroidism, hematologic malignancies such as leukemia, and then most relevant for our specialty, dementia from Alzheimer's disease. And over the decades, the life expectancy for individuals with Down syndrome has continued to increase and is now well into the 60s. And so it's increasingly important for us to focus on the aging challenges of individuals with Down syndrome, particularly with Alzheimer's disease. Down syndrome is considered a genetic form of Alzheimer's disease, and over 75% of individuals with Down syndrome over the age of 65 years old will have developed Alzheimer's disease dementia, and this is 6 times greater than the general population. As you can see here, much of the neuropathological changes that we know are associated with Alzheimer's disease, such as the amyloid beta plaques and the neurofibrillary tangles, they're accrued quite early in life and present in almost all individuals by the age of 40 in individuals with Down syndrome. The clinical presentation of dementia also begins quite a bit earlier, often 30 to 40 years earlier than sporadic forms of Alzheimer's disease. As the life expectancy of individuals with Down syndrome increases, of course, the relevance of Alzheimer's disease diagnosis and management are becoming increasingly important to both researchers and to clinicians like ourselves. As mentioned, Down syndrome is considered a genetic form of Alzheimer's disease. The main theory is related to this extra chromosome 21 material. The amyloid precursor protein, also referred to as APP, is its genetic material is located on chromosome 21. And given the extra chromosome that's present, there's of course a 1.5 times increased production of APP. And that leads us to briefly talk about the amyloid hypothesis of Alzheimer's disease. So as you can see here, APP is produced and then sits in the cell membrane, and then it's cleaved by an enzyme known as beta secretase. Afterwards, gamma secretase comes in and will cleave the remaining membrane-bound portion of the protein, releasing what we know as amyloid beta peptide. The length of this peptide depends on how it was cut by gamma secretase, but can either be 40 or 42 amino acids in length. And amyloid beta 42 is more likely to cause amyloid fibril formation, which then leads to plaque production. However, we know another major component involved in Alzheimer's disease development is related to the intracellular tau-containing neurofibrillary tangles in the brain. And while for many years, the pathogenesis of Alzheimer's disease was thought to be related to amyloid beta that precipitates the disease process, leading to a cascade, there's greater thought now that these two pathways are probably having synergistic effects. And so although this flow chart seems to present things in a very linear fashion, starting with amyloid process, the two work together and eventually we end up with neuronal death, cell damage, and the cognitive impairment that we see clinically. Now, bringing us back to individuals with Down syndrome, anecdotally from conversations I've had with others and also supported by the literature, there are many challenges with diagnosing dementia in individuals with Down syndrome. The greatest challenge is related to the underlying level of baseline intellectual disability, which can vary across individuals. This requires a key informant to provide a reliable and detailed cognitive and functional history at baseline and then at every follow-up visit, which can be used to help inform the diagnosis. Unfortunately, due to the varying levels of intellectual disability, individuals with Down syndrome will perform at 4 scores on traditional cognitive tests that we're all comfortable with performing. The presence of floor effect essentially means that even in the absence of any cognitive impairment, individuals would receive low scores due to their intellectual disability. And therefore, these tests are not going to be sensitive to any change in terms of their cognition. And this renders the traditional cognitive tests inappropriate for use when evaluating patients with Down syndrome for cognitive impairment. And at this time, we still don't have any gold standard test that's recommended for use in assessing for dementia in individuals with Down syndrome. Many research groups, however, have developed various tools to help clinicians assess for major neurocognitive disorder in individuals with Down syndrome. One of the tools here is the Cambridge Examination for Mental Disorders of older people with Down syndrome and others with intellectual disability, also referred to as the CAM-DEX-DS. So this is a multi-component comprehensive tool, which first begins with an informant interview, which is demonstrated here in terms of how it's printed out. And this is completed with the patient's caregiver or someone who knows the patient well over their lifetime. And it runs through questions pertaining to their functional status with an emphasis on establishing change from the patient's prior baseline best functioning. The interview component itself has a sensitivity of 88% and specificity of 94% for detecting dementia, with good inter-rater reliability as well. The second part of the CAM-DEX-DS, which can be used separately from the entire assessment, is a cognitive test known as the Cambridge Cognitive Examination for older adults with Down syndrome, which I'll refer to as the CAM-COG-DS. Now, this is a cognitive test that can be completed in about 20 to 30 minutes, and patients can receive a score out of 109 points. It assesses multiple cognitive domains, including orientation, language, memory, attention, praxis, calculation, abstraction, and perception. The utility of this test, however, is that it's best applied when it's performed serially on a patient, as a single score at a given time has limited diagnostic value. Therefore, when it's used together with the informant interview, together it can help to identify areas of cognitive decline. Lastly, another cognitive test that has been shown to be helpful in detecting cognitive decline attributed to Alzheimer's disease in individuals with Down syndrome is a modified version of the cued recall test. This test, however, only evaluates episodic memory. The test is here depicted on the left, and essentially it starts with a learning phase where the patients are presented with a list of items, and they start out with 4 items, and each of these 4 items belongs to a semantic category. For example, grapes here belongs to the semantic category of fruit. And during this phase, the participant is asked to point and name to items in response to the verbal presentation of the semantic cue. And this essentially ensures that they have attended the word with the associated cue. They're presented with these 4 items on the card, and they have to be able to demonstrate that they can immediately recall all 4 items to ensure that they have been learned. And a total of 3 learning tries are permitted for each card, and then they move on to the next card and perform the same with each set of words. This is then followed by the testing phase, where participants are asked to recall all items on all lists, first without any cues for about 1 minute, and then the same cues are provided for the omitted items. The testing phase is then repeated 3 times with a total score out of 36 being allowed. And points can be allotted both for free or cued recalled items. A recent study evaluating the use of this test in individuals with Down syndrome found that a score 33 and higher was highly sensitive for ruling out Alzheimer's disease dementia and fairly sensitive for mild cognitive impairment, whereas a score lower than 20 was highly specific for Alzheimer's disease dementia. A caveat of this test, however, is that it can't be used for those who have identified a severe intellectual disability at baseline due to concern about floor effects, or if they have any kind of visual sensory impairment, of course, because the visual cues are important as a part of the learning phase. Prior to this study, there remained some gaps in the area of Alzheimer's disease research in individuals with Down syndrome. There had not been many studies that had assessed individuals with Down syndrome longitudinally for Alzheimer's disease-related cognitive decline, and the studies that had been completed had relatively small sample sizes on the scale of 100 to 150 patients. One of the recent studies looked at PET imaging as a way to estimate the burden of amyloid beta in the brain and suggested that there's an early decline in episodic memory and executive functioning in those with more amyloid beta burden. They similarly used the cued recall test and found that a change in cognitive results resulted or correlated with a change in the amyloid beta burden status. These studies, however, did not necessarily stratify results based on age or baseline intellectual disability. And we generally know that age of onset varies from individual to individual, as does the baseline intellectual disability. And these could be important prognostic factors relevant to diagnosis, prognosis, and counseling. Lastly, despite the relevance of Alzheimer's disease research and therapeutics to the Down syndrome population, these individuals are often excluded from clinical trials due to perceived difficulty with recruitment or differences in baseline characteristics compared to patients with sporadic forms of Alzheimer's disease. Now we'll move on to our paper. So the study question presented in this paper was, are age, intellectual disability, and clinical status associated with Alzheimer's disease progression and longitudinal cognitive decline in individuals with Down syndrome? Given this is a longitudinal cohort study, the study question can be framed according to the population, the prognostic factors, and outcomes rather than our usual PICO format. Here, the population included adults with Down syndrome aged 18 years and older. The study was completed in Barcelona in Spain, so all patients were Spanish speaking. Participants were drawn from a population-based health plan designed to screen for Alzheimer's disease in individuals with Down syndrome. And prognostic factors assessed in the study included the patient's age, baseline intellectual disability, their clinical status at the time of initial assessment, and their sex. There were 2 main outcomes that they were looking at. They wanted to look at the clinical change along the Alzheimer's disease continuum, which I'll explain a little bit further in the next few slides, and then looking at changes in the cognitive scores on the testing over time as well. Now, as a part of their assessments, all individuals first had, of course, an initial visit completed. And at this visit, they collected baseline characteristics, as well as a sense of their baseline level of intellectual disability, which was based off the DSM-5 criteria for mild, moderate, severe, or profound intellectual disability. All individuals underwent a medical examination, which consisted of the CAM-DX interview, which I spoke about earlier, And the cognitive testing, including the CAM-COG-DS, as well as the modified cue to recall test that we spoke about earlier as well. These two portions were completed by two separate clinicians who were blinded by the other respective assessment. And at the end of the visit, the clinicians would reach consensus of a diagnosis and classify the individuals according to a particular Alzheimer's disease status. At subsequent visits, the medical and cognitive tests were completed again, unless they had been identified to have severe or profound intellectual disability. These individuals did not receive repeat cognitive testing on the subsequent visits because they were felt to have floor effects. Whereas if they had mild or moderate intellectual disability, they would receive the full assessment, including repeat cognitive testing. At the end of the subsequent visits, a repeat diagnosis would be given, and then individuals would be then categorized as being a progressor or non-progressor in their clinical status. Of note, the study visits were completed between November 2012 and December 2021. Now, regarding the diagnostic classifications, patients were classified into one of the four categories here. They could be asymptomatic, meaning that there was not yet any clinical or neuropsychological suspicion of Alzheimer's disease. They could have prodromal Alzheimer's disease, meaning that there was some suspicion for Alzheimer's disease, but the symptoms did not yet fulfill criteria for dementia. They could have Alzheimer's disease dementia, meaning that they met criteria for dementia, there being both functional and cognitive decline. Or lastly, they could have uncertain or non-degenerative neurocognitive disorders, such as due to concerns about medical comorbidities or medication side effects that might affect someone's functional status, but not thought to be related to neurodegenerative and pathology. Then at the subsequent visits, the individuals were classified as being a progressor and non-progressor. And essentially, this is just related to whether there was a change in their clinical diagnosis along the Alzheimer's disease continuum. For the analysis, they had two major components. So they first generated Kaplan-Meier curves to assess clinical progression for those who were asymptomatic and then became symptomatic, and those who had prodromal Alzheimer's disease and then developed Alzheimer's disease dementia as endpoints. And this was done for the whole sample for specific age groups and then also by sex. Secondly, they completed linear mixed effects models to assess for longitudinal cognitive decline as a function of age. They looked at cognitive test scores as a function of time, and then finally annualized change in cognitive scores as a function of baseline cognitive performance to assess for floor effects. Linear mixed effects models essentially allow the researchers to account for multiple fixed and random effects and are helpful when you're measuring multiple data points for a given individual from a large sample size, as Peter had spoke about just recently. Participants may also belong to multiple subgroups. For example, there's different age categories or subgroups based on diagnoses. And it allows you to account for random effects. And in the study, they set the patient-specific intercepts and the slopes as random factors, which essentially allows us to account for the variability from the mean and allows us to better identify the overall trajectory, for example, of the cognitive decline or the changes in cognitive scores in comparison to a set function. Whereas in a standard linear regression model, you can only account for fixed effects. Now moving on to the results in table 1 with the baseline characteristics of these patients. So the total study, like the total sample size was 632 patients, all of who received a diagnosis along the Alzheimer's disease continuum, and none who had that initial category number 4 where they were categorized as uncertain or non-degenerative neurocognitive disorder. On the left here, this includes the whole sample who were at a minimum followed with informant interviews to guide diagnoses along the Alzheimer's disease continuum. And then on the right here, it includes only those who had cognitive follow-up and excludes those with severe and profound intellectual disabilities due to floor effects. The majority of individuals were asymptomatic, and asymptomatic individuals tended to be younger and had higher cognitive scores than patients with prodromal Alzheimer's disease or Alzheimer's disease dementia, without surprise. There was no significant differences in the sex distribution across the diagnostic groups, but there were, however, differences in intellectual disability in that there was generally a higher proportion of individuals who had moderate intellectual disability across all groups. The mean time for follow-up for the whole sample was 28.8 months, with longer follow-up duration generally in the asymptomatic individuals. Now moving on to the first set of Kaplan-Meier curves, where the time to event is dependent on the group being analyzed. In the first figure here on the left, this includes all individuals who were asymptomatic at the first visit, and the event is the presentation of symptomatic Alzheimer's disease, meaning either progression towards prodromal Alzheimer's disease or Alzheimer's disease dementia. Overall, after 5 years of follow-up, 17.1% of the asymptomatic individuals had progressed to symptomatic Alzheimer's disease. On the right side of figure here, this includes all individuals with prodromal Alzheimer's disease, and the event outcome is the progression towards Alzheimer's disease dementia. And as you can see here, after 5 years of follow-up, 94.1% of individuals with prodromal Alzheimer's disease had progressed to Alzheimer's disease dementia. The authors then stratified the results based on age subgroups. So this Kaplan-Meier curve, once again, is looking specifically at the asymptomatic individuals at the start of the study and their progression towards symptomatic Alzheimer's disease. As you can see here, there's clearly an age-dependent progression towards symptomatic Alzheimer's disease, where in the oldest category, individuals over the age of 50 years old, 57.5% of individuals progressed along the Alzheimer's disease continuum, whereas in the youngest category, those less than 40 years old, only 0.6% had progressed. Now, when we look at the age subgroups in those with prodromal Alzheimer's disease at the start of the study and followed them through 5 years, you can see that there's no age-dependent process that's seen. And altogether, the total was 94.1% of individuals having progressed. Now, this is actually from their supplementary data, but I thought that it would be important to highlight. They did find that there was a sex difference between males and females in those with baseline prodromal Alzheimer's disease, in that females progressed significantly faster than males, but there was no statistical differences in the asymptomatic sample. Now, moving on to the analyses and looking at the results of cognitive testing. Of note, these analyses exclude individuals who had severe to profound intellectual disability, as a reminder, because they were expected to perform F4 effects. I recognize that this slide looks very busy, the figures, but I will walk you through it. So the overall message or result gathered here that the authors were trying to depict is that the difference between those who have mild versus moderate intellectual disability, with those with the mild intellectual disability in gray performing at overall higher scores across the age continuum compared to those with moderate intellectual disability in orange. This pattern is seen with both of the cognitive tests that they use, the CAMCOG-DS and then the MCRT. This is a collective of all the scores that they attained during the study, including both baseline and follow-up visits. They also found that there was no interaction between intellectual disability and age. So regardless of your baseline intellectual disability, your expected trajectory itself should not be influenced by that and is more so related to your age. You may notice that there's an initial rise in the lower age brackets, and the authors attribute this to practice effects, which I will explain a bit further in the coming slides. Now, here's another way of depicting a similar message, but instead of plotting the raw scores, what you're looking at is the annualized change in scores, which was calculated by taking the follow-up score subtracted by the baseline score and then dividing that by the years between the time points of testing. As you can see here, there's no change in the score related to mild and moderate baseline intellectual disability, where the slope is very similar between the two. And in the younger years, the change in score tended to be net positive in that it's above the line of 0 here on the y-axis. And this is related to what they thought of as practice effects. And later on, they become net negative and scores decline as you get older. Now here we're focusing only on individuals who were asymptomatic at baseline. The authors found that the practice effects were seen in the first 2 years of follow-up. And so they estimated the trajectory of cognitive scores for the first 2 years of follow-up in year 3 to 5 separately so that they could separate out these practice effects. The practice effects were more prominent on the MCRT episodic memory test. And as you can see here in the first 2 years, the slope is generally positive, particularly in the younger age groups due to these practice effects. Thereafter, the slope for most age groups becomes negative. And this is another way of demonstrating these practice effects, especially in the younger age groups, and particularly for those who were asymptomatic at baseline. It's likely that the practice effects seen in the previous graphs were driven by this asymptomatic group. It's also important to note that they included all asymptomatic individuals here, those who progressed and didn't progress. And we know that older adults generally are more likely to progress, which explains perhaps why the slope is much more steep in the older individuals here. Here we look at the overall progression in average scores based on the diagnostic subgroups, where they divided out the asymptomatic individuals who did not progress in the solid blue line here from those who did progress in the dotted blue line, and those who had prodromal Alzheimer's disease and dementia separately. You can see that those who are asymptomatic at the beginning and don't progress have stable or improved results over time, whereas in all of the other groups where there's progression in terms of their diagnostic criteria, you can see that their cognitive scores decline, which makes sense given the progression along the AD continuum. Lastly, the results shown here, they're trying to demonstrate the floor effects, particularly on MCRT. Once again, I recognize this is a busy slide, but on the y-axis here, we have the annualized change in scores, and on the x-axis here, we have the baseline cognitive scores. You can see that lower on the x-axis, this represents lower baseline cognitive scores on a test, and 0 on the y-axis demonstrates the absence of any kind of change in the score from one year to another year. Ignoring the asymptomatic individuals in the solid blue line, I want you to pay attention to those who moved along the Alzheimer's disease continuum. For the CAM-COG-DS, you can see that the scores declined similarly for all baseline scores, in that they're all below the line of 0, except for those who are asymptomatic. The longitudinal decline is therefore independent of the baseline score, showing that you continue to have variability, particularly in those with the prodromal group in orange. And even if you have low baseline scores, you tend to continue to have a change in your cognitive test scores over time. However, with the MCRT, you can see that those who had relatively low baseline scores tended to hover around the 0 mark on the y-axis, meaning that the longitudinal decline is dependent on the baseline score. This means that there are, in fact, floor effects with the MCRT test, in that when the scores are already so low, they're unlikely to change in a meaningful way, and that's going to be important when you're interpreting the results for your patients in the clinic. And what we can learn from this is that the MCRT is going to be most helpful during the earlier stages of the Alzheimer's disease continuum, such as moving from the asymptomatic Alzheimer's disease stage to prodromal Alzheimer's disease. But in those who have already developed prodromal Alzheimer's disease or dementia, it may not be as helpful at detecting further cognitive decline, especially if the baseline scores are already very poor. Whereas in the CAM-COG-DS, irrespective of the diagnosis and the baseline scores, there continues to be an annualized change in the score, meaning that this test is going to continue to pick up on decline across the various cognitive domains, and that may be helpful for interval reassessments for your patients. Now, moving on to our critical appraisal of this paper, beginning with the internal validity. So was the defined representative sample of patients assembled at a common, usually early point in the course of their disease? So no, not necessarily, but I think given the goal of the study, which was to look at the impact of baseline clinical status along the Alzheimer's disease continuum and age, it was necessary to include individuals from different age groups and also individuals from different points along the Alzheimer's disease continuum. Perhaps a better design would have been to recruit only individuals who started out as asymptomatic and follow them throughout their entire trajectory, because we don't necessarily know at what time frame those who had prodromal Alzheimer's disease were necessarily recruited within their disease trajectory. Additionally, the Kaplan-Meier curves, I think they appropriately assess the relevant outcomes, such as the change along the Alzheimer's disease continuum, and they did so for the whole sample and also for the different age subgroups. Was patient follow-up sufficiently long and complete? Yes, I think so. The follow-up was variable across individuals. And to me, it's not entirely clear on average how many visits per individual and whether that was variable between individuals with differing baseline diagnoses. But regardless, some individuals were followed up until 5 years. And overall, this was sufficient to demonstrate the progression in individuals with prodromal Alzheimer's disease and to highlight differences in progression between age groups and those with asymptomatic Alzheimer's disease at baseline. Were outcome criteria either objective or applied in a blind fashion? Yes, to some degree. So at each visit, all individuals were assessed by both a neurologist and the neuropsychologist who had independently reached a diagnosis and classification for the patient. They were blinded to the rating provided by the other clinician, and then a consensus diagnosis was determined afterwards. However, it's not necessarily clear to me whether the clinicians were blinded to the diagnosis received on the initial visit. And I think that would have been helpful to prevent bias, particularly those who were identified to have progressed along the Alzheimer's disease continuum. If subgroups were different, with different prognoses are identified, did adjustment for important prognostic factors take place? Yes, subgroup analyses were completed and accounted for age, sex, and underlying intellectual disability. However, the study also didn't look at the patient's ApoE genotype, where certain allele patterns may result in an increased or decreased risk of Alzheimer's disease. Now, moving on to the results. How likely are the outcomes over time? In those with prodromal Alzheimer's disease, the progression towards Alzheimer's disease dementia occurs within 5 years and is irrespective of age. And we also learned that females progress faster than males. In those with asymptomatic Alzheimer's disease, there is going to be an age-dependent risk of progressing along the Alzheimer's disease continuum, with older adults having a higher risk of progression. And how precise are the prognostic estimates? Bringing back the main results with the Kaplan-Meier curves, you can see that the confidence intervals for the whole sample are relatively narrow, showing quite good precision. But for the both for the asymptomatic group and also for the prodromal Alzheimer's disease group. The confidence intervals for the age subgroups shows good precision for those who are less than 40 years old, but becomes less precise in the older individuals. And this may be attributed to smaller sample sizes in the older age categories. However, for those who have prodromal Alzheimer's disease at baseline, there is still a fairly adequate confidence interval, even though the total sample size was relatively smaller. And this was part of their supplementary data, so they actually didn't include the confidence interval for this subset of data where they compared the differences between males and females, unfortunately. Lastly, can we apply this evidence about prognosis to our patients? Likely, but I think there's a few differences that we can consider about this sample population. So this population were all Spanish speaking, meaning that cognitive testing was also done in Spanish. All participants in the study were actually part of this health plan that was designed to screen for Alzheimer's disease in individuals with Down syndrome. I think in our clinical practice of geriatrics, by the time patients are referred to our care, they're likely already going to be in a prodromal Alzheimer's disease stage or may already have a diagnosis of Alzheimer's disease dementia, rather than us being the clinicians involved in baseline screening and then monitoring for cognitive changes. And so we're likely seeing patients already at a later stage of their disease process. So finally, the bottom line. So this has, as far as I'm aware, it has been the largest cohort study performed so far on individuals with Down syndrome to look at prognosis of developing Alzheimer's disease dementia. And it accounted for multiple prognostic factors, including age, baseline intellectual disability, sex, and underlying cognitive diagnosis. The main takeaway from this study is that they found in individuals who did not have any signs or symptoms of dementia, the risk of developing symptomatic Alzheimer's disease is dependent on age, with older individuals having a higher risk of progression towards symptomatic Alzheimer's disease. However, once patients are in the prodromal stage, progression towards dementia will occur irrespective of your age and within 5 years. Additionally, the underlying intellectual disability of a patient does not impact the rate of cognitive decline over time, and therefore we can monitor those who have mild or moderate intellectual disability at a similar rate in terms of follow-up care. Here are my references. Thank you for your attention and time. I welcome any questions or comments.
Thank you very much, Victoria. Beautifully presented, exceptionally clear slides. There are some comments and questions in the chat box. I want to say also that from my time in the community, I did see a good number of these patients, but less so now in the academic setting. But I did receive a lot of referrals when I was practicing in the community for these patients. So Irene Turpey, and I want to thank all the community geriatricians who are online with us today for joining. And Irene Turpey says, was education, I know baseline intellectual ability you highlighted, but was baseline education accounted for?
Yeah, that's a very good point. They didn't comment on the baseline educational status. So I think in terms of prognostic factors or like protective factors, that's a very good point that it would be important to consider that in future studies.
And Carol Cohen asked, how common is it for geriatricians to see these patients in Toronto? I mentioned my experience. Perhaps others in the city may see these patients more often. Happy, Gary, I see your hand. I'm just going to finish one last comment in the chat box. And academic geriatricians, if you do see these patients, please feel free to respond in the chat box. Marjorie Hammond asks, were all participants community dwellers?
Yeah, also a good question. So I suspect that they mostly were, because they were followed quite longitudinally from this health care program. But they didn't necessarily specify, like, if someone ended up being institutionalized, like they didn't comment on that along the Alzheimer's disease continuum. But I suspect that at the time of recruitment that these patients were.
Go ahead, Gary.
Thank you, Victoria. A great presentation. So just one question: when you presented sensitivity specificity results for some of the cognitive tests specific to Downs, can you please tell me what the gold standard was against which these tests were assessed? And then just a comment is, in people with Downs, much like people maybe in younger life have traumatic brain injury, there has been increased question about, and also actually people with ADHD, is the extent to which sort of regular or normal aging changes in cognition in people with a different reserve might impact some changes in cognitive scoring that are hard to take account for. And particularly with Down syndrome, there's could be quite a variability in terms of education, cognitive stimulation that these individuals receive that may impact their cognitive reserve. Thank you very much.
Thanks. Thanks for bringing up the sensitivity and specificity. In that study, they compared it to just like a clinician diagnosis based off the DSM-5 criteria. And from the literature, when I read what they consider as like the gold standard diagnosis, it's still like clinician interview informant to make the diagnosis rather than any other additional supplementary like tool per se.
Thank you very much. With that, that brings us to 9 a.m. precisely. I want to thank our two presenters today for, as always, just exceptional presentations. Thank you, Peter and Victoria. Some applause going around in the icons. As a reminder, or by way of announcement, please remember to complete your evaluations that were circulated about 10 minutes ago. And I wish everyone a very good weekend.